any questions that y'all may have.
I guess my question, because I'm a numbers guy, I told you that.
Yeah.
I guess to me, and you two would know better than me because you do it every day. Do you feel like the algorithm validated what you did? And I would say looking at MMEs, it did, but the target changes. Do you think it needs to change? So do you think the formula worked? And do you think it needs to change based on what you see out there, Carlos? Because because things move, right?
Yeah, they move. And I'll add one other thing to when we started this program. The DEA also came into our meeting and they pointed out to us that the state of Arkansas at that time had the second highest per capita prescription rate in the country. So we were a target also, the DEA. And the DEA came in, and I appreciate their input, but they also said if we don't fix it, quote, they will. Their idea of fixing it was they literally said, we'll arrest 5 doctors in the state for overprescribing. That's how they would shut it down. So we also stepped up then like, okay, it'd be a lot easier for us to handle it because I don't want to see doctors getting arrested, particularly some who aren't, malignantly doing something wrong. And we never wanted to turn this into a witch hunt of our physicians. We wanted to educate and correct it that course. So there was also a big input by the DEA because the state of Arkansas was stuck out on their criteria. And then again, the main thing we went to, particularly in discussion with the DEA, were the high street value drugs and the drugs with high diversion. The pure drug formulations, particularly high oxycodone 30s, the oxycodone 20s, and Dilaudid, which has a notoriously high euphoria to it. I mean, there is a reason we don't prescribe heroin in this country because the euphoria off the drug is considered non-medical. So we look for those things that really appeal to drug abuse. We try to get the age because I think that is also very important. I mean, if you got an 80-year-old taking a bunch of oxycodone and they're on Plavix and Eliquis and they can't take NSAIDs. I mean, it's you don't want to go after that patient population. So we addressed it from that standpoint. I think when we call those doctors in, I hope we've done a good job in getting that real big element out of the way and also looking for the cash clinics, the pain clinics out there that are just taking cash money and don't take any insurance. That is a huge, it's one thing if you're a plastic surgeon, it's a different thing if you're prescribing opiates. I think that's a very gray area, and so does the DEA. So I think as far as, do we change the metrics around? Definitely not opposed to, as we see the data change, I think we've done a good job on actually across the state. I think word got out pretty good too, that, hey, this, if you're going to put out these oxycodone 30s and you're not a palliative care, you better have a really, really good reason as to why someone's on that amount of drug. So I would be happy to look at different metrics on that. And I'd love the feedback, constructive for both of us. And I'll let Ron talk about because he's been great on our committee.
Just one thing I would say, I know you guys mentioned a lot of the board members are new. When we first started this, before we had these metrics, what we were seeing was we were just getting these reports on physicians that we should look at. And it turned out that basically they were the busy pain guys, because they had the most patients, they had the highest number of prescriptions, because if that's all you do all day long. And, just to go back on the 640 per month, if you really think about it, I mean, most doctors see more than 4 patients per hour. I mean, you have to keep the doors open for a lot of people. So that's really not a huge number. And so what we saw initially was we were getting that. And so then we met with this, and we also started to notice, the guys the DEA are looking at are not the same guys we're looking at. So why is that? What's going on? And so then we started coming up with different metrics from Ohio. And so that's what we wanted to see is really, we don't want to just pull the busiest pain guys, because with all this opioid phobia, nobody wants to ride them. And if you start cracking down on the busy pain guys, nobody's going to take care of these patients, and they need help. A lot of these legitimate patients do need help. And then number 2, we wanted to see really, we're missing a lot of the troublesome prescribing that the DEA is seeing. We're not seeing that. We're not pulling that with our data analysis. So how do we change that? And that's what we came up with. And I think once we did this, I mean, we saw our lists and the I guess the data really kind of changing. And then it started to align a little bit more with some of these hot spots that the DEA is telling us they're focusing on. All of a sudden our metrics started shifting and we're pulling people out of there. I'm not saying it's perfect by any means, But I mean, we're always open for input, but I think it's better than it was. Let's put it that way.
I guess my thing is just I've heard about these pharmacies getting shut down and things like that. Hey, John, would you come up here and give me some idea of what y'all see as the metrics that impact y'all? Yeah, you can steal a microphone over to the left, do whatever you're gonna do, but because to me, man, I would love for like all of these boards to kind of
Real quick, since the institution of these metrics, it says that Arkansas was really one of the worst. Have we improved any?
We have. Oh, yeah.
Our opioid dispensing is down. The CDC, according to 2020 data, they have not updated that since 2020. We're still number 2, but we're decreasing.
Right. So everybody's gone down, Brad,
Everybody's
but
going down.
Arkansas, Alabama, Mississippi, Oklahoma, right there in the middle, we are still the warmest in the country. And if you look at combos, that's some of my concern. Combos, Arkansas has dropped a ton. I've got a graph in front of me from 2016 to 19, but we are still the outlier.
Yeah.
We are number 1. And that's where when I look at the metrics, I wonder, but you guys do it every day. And then John's end is totally different. Walmart's trying to take it on their own, and that's their prerogative. But when you talk about like the DEA said, I'm going to come fix it, Walmart decided they're going to come fix it in Northwest Arkansas, it sounds like.
Well,
But are the numbers, if they're 3 years old though, I mean, how often do they update those? Do we know?
You'll have to ask the CDC that.
Okay.
Based on our data from 2022, like we can do analysis on the data we get, we're still decreasing. We
Okay.
decreased in opioid dispensing every year.
Okay.
And I think one thing we have to be careful of too, and we've talked about this, we get fearful on the pain committee because they're putting so much pressure, and with opioid prescribing is coming down, and we think that's great. We all want that. But we've noticed that the illicit abuse and the opioid, I guess, overdoses are not coming down in proportion to prescribing. So we just want to make sure that we're focusing on the right thing. And the other thing, I know one thing we pointed out several times and talked about in the committee, Arkansas is high. Arkansas is not a healthy state. I mean, we're high in obesity, we're high in smoking, and we're high in patient population. And those 3 things right there, that sets you up for high opioid prescribing. So, I think we just have to be careful in trying to target what we're really looking at. And I know the pharmacies, we've talked to a lot of pharmacists. I've talked to several. We're seeing that some of the main chain pharmacies are starting to just blackball prescribers. They're just saying you can't fill here anymore. And I don't know if that's a good thing.
I want to add,
Right, Jamie, and then we've decreased every year on the numbers, right?
Since 2015,
Right, and
yes.
Right, that's what I thought.
That's as far back as
I want to add something about the overdose deaths, and then I'd love for you to address this on a pharmacy line. I've been on this committee since it started, so like 2003. I will say this, and I think I applaud the committee, and I applaud, like Dr. Pierce and some of the chairs of this board who've been very brave in addressing this issue. One thing that when I used to review cases, and this is before you got there, we reviewed cases every time with multiple overdose deaths related to a physician prescribing. I have not, thank God, had a complaint to the board, and I don't know that y'all have seen them, that a parent writing a letter to the board, this doctor killed my son or my daughter. We used to get those kind of reviews all the time. So the overdose deaths, and I think as physicians, when we're not contributing to that overdose death issue, we've done a huge job. And I'm really very grateful that we've not seen the mess that we saw in the 2000s, 2008, 2009, 2010. I literally reviewed charts with 25 overdose deaths related to a single physician. It was madness. The thing with the overdose continuing to rise, fentanyl is accessible across the southern borders. We have a government issue that we have a free flow of fentanyl. These overdose deaths are no longer are the doctors the leading cause of overdose deaths. That was not true 10 years ago. And that was a stain on medicine and pain management in particular. One of the things I have, and you can address this, when our patients, they can't get opiates at pharmacies because they're not supplied. Where do they go? They're going to go to the street. You create a state of desperation in good people, normal people, when they can't get the opiate and they go through withdrawal. That's not an addiction issue. They're desperate to get out of that state of withdrawal, and they will go to the street. They will get things, and that's where you're seeing it. And so there's a huge issue that the pharmacies aren't carrying it. The government's not doing their job by curtailing the legal supply of opiates to the pharmacies. They're exacerbating the problem and they're causing overdose deaths, and they are creating the market for illicit drugs and fentanyl coming across the border. So the government is allowing the supply out of Mexico and doing nothing to help the medical professionals treat those patients. So we have a huge problem. That's a federal problem too. But the idea of the overdose deaths, fortunately, are no longer, I think, a stain on medicine, but it's a stain on our federal government. And honestly, the pharmacies need an obligation to supply a reliable, ample flow of opiates to the citizens of this state. I mean, cutting a 75-year-old patient off of their oxycodone when they've got severe spinal stenosis, they walk with a walker, and that's how they get about every day. They're on Eliquis, they can't take NSAIDs, is really almost criminal to me that we have a system that is this dysfunctional. So the pendulum has almost swung too far the other way. And I'd love to hear your input on that and what we need to do, be it legislatively, working with you guys to correct the opiate supply problem. And that will cut down on the number of deaths that are coming, not from the doctors anymore, but from the drug cartels.
Sure. Thank you, Mr. Chair. I'm John Kirtley with the Arkansas State Board of Pharmacy. And I think what you basically tied in, Dr. Roman, is a good plug for you should come to the drug summit this fall, because John Vinson with the Arkansas Pharmacists Association and I are both going to co-present for 2 hours, literally about the controlled substance drug supply and the issues that we're seeing with this. And I think that a lot of our prescriber community, especially, in fact, I think a lot of our pharmacy community does not understand that in many instances, the decisions pharmacies are being forced to make is because they are unable to actually get the drugs. Over the years, you look at DEA had an allowance that there's a specific number of controlled substance doses that can be manufactured. And they used to allow an overage over that number of up to 25%. So over the years, DEA has cut that to where 100% is 100%, and that's it. We have had supply chain issues with controlled substances. You can see it especially right now with ADHD drugs due to a couple of manufacturers that are not being resolved. At the same time, we have an increase in ADHD stimulant prescribing. One of the big things that John Vinson and I have been involved with and really trying to put our heads together on is that in this squeezing of the balloon, Dr. Gardner, you're exactly right. We are in a hot spot area that if you look at the statistical information from CDC for the entire country, everything has gotten paler in comparison of the entire country has come down, but we are not catching up with the rest of the country as far as our overall controlled substance prescribing rates, and it makes us stick out. So we are a target. And because of us being number 2 in opioid prescribing and number 1 in combination prescribing, when you talk about with muscle relaxants or benzos, then it is hitting pharmacy supplies more in Arkansas than anywhere else in the country, except maybe Alabama, but I don't know that I'm hearing it as much out of Alabama. So we, on a daily basis, the Board of Pharmacy and the Attorney General's office are getting notifications from wholesalers that these are what we deem to be suspicious orders, which the suspicion is it oftentimes has exceeded a threshold amount that a wholesaler sets up that they will not sell more than X number of this type of medication to pharmacies. And so the pharmacy tries to order it every single day until the threshold number, something is rolled off and they have some more availability. It's seen as a suspicious order. Most of this revolves around some federal injunctive relief around the big 3 wholesalers, but it is something that none of us have the authority to do anything with. We're working with the Attorney General's office through ADH and the Attorney General's office to meet with some of those companies to have discussions on this. But the ultimate, many people would say, gun to the head scenario is we have pharmacies that are given letters that we have reviewed your dispensing practices. They're not saying that the prescriptions are illegal. They're not saying that they're from unlicensed people, but we have reviewed your dispensing practice. And because of our obligation with controlled substance distribution to you, in 5 days, you get no more controlled substances. You can appeal and they may extend it to 15 days. But we have had a couple of pharmacies in Arkansas that literally had 5 days notice. One of them was able to get it extended to 15, but they got no more controlled substance from their main wholesaler that day. So if you want to talk about disruption, the overall, back allegation is I would say you can't really push a rope. Prescriptions are coming in. Pharmacy is trying to fill prescriptions to give to patients. They are ordering more and more controlled substances until the supply gets cut off. So many of these, even large corporations that are paying hundreds of millions of dollars in their lawsuits, they're having to look at where are our areas of risk. And part of my argument has been if you as a major corporation see a prescriber that you believe is problematic, you should report that to the medical board. You should report that to the nursing board or the dental board or whoever it is, to let that oversight board also look at whatever information you're having at your disposal. Because, quite frankly, Walmart, they have thousands of stores across the nation. CVS does, Walgreens does. If they see a pattern that is different than we can see in our own PDMP information, or that they see slightly differently because they're looking at it differently, then we ought to know that as oversight boards in the state. So we're going to talk about it for 2 hours at Drug Summit. I think it'll be really good. I think it'll be really frustrating for a lot of people because we're going to kind of pull back the shade over what is going on for a lot of the pharmacy side and the drug supply side.
I think, and I appreciate a lot of the pharmacist input, but we get some that are, I had a patient literally who had one of our construction workers that works on our freeways every day, got hit by a car, was a UMS, multi-orthopedic trauma. This guy did not walk for a year. He goes in, he left UMS. I took over his care for his pain management. He goes to a pharmacist, guy's in a wheelchair, external fixation on his leg. They're trying to salvage a limb. The pharmacist, it's a true story, just one of these crazy things, calls me and says, I'm not filling his prescription. He doesn't need these medications. And then when I rebutted her, she said, I'm going to report you to the board. With some of this, when they inject themselves into the practice of medicine, and some of it has been so obscene that it's just unconscionable. I mean, I was told the limb, like, okay, well, report me to the board. He'll go to a different pharmacy. I need to get the prescription out of your system to somewhere else. So that's been one issue where there's been sometimes been some overzealous overreach on that. The other issues is with the larger pharmacies not wanting to take on the prescriptions because all the lawsuits. Of course, I do question, where did all these literally billions of dollars go? The lawyers, I'm sure, private jets, I got a place in the Cayman Islands, did nothing to address the drug issue. But when the large corporate pharmacies like Walmart and Walgreens, they won't cover, then the small mom and pop pharmacies, they end up with the burden of the prescriptions. And then they come up on the DEA drug screen or the FDA and they say, hey, Rose Drug here, that's an outlier pharmacy. Now they're the ones putting all the opiates out. So then that little pharmacy gets investigated, right? Or they shut them down. They don't get the supply. And so we had this disruption where these corporate guys, they're so afraid of being sued. And then the little guys are getting scrutinized. They can't get the drugs. It is a extremely dysfunctional pharmacy system where the corporate pressure pushing on the little guys and the little guys get squeezed by the DEA, FDA. It is a huge problem. And again, it leads to illicit drug use, state of desperation. You can't just cut someone off of an opiate. Even when you turn the ship with these large opiates, we give some of these doctors we check them at 6 months and 1 year to see their prescribing slowly come down. You cannot medically just cut a chronic opiate, a chronic benzo patient off of a drug and we're just not going to prescribe anymore. That's not the practice of medicine. That is cruel. That is, you're going to put these people in acute withdrawal. They're going to do desperate and crazy things. And that's something that needs to be addressed too. This ship, I don't see where we're going to go from number 2 to number 25 overnight, but if we're drifting in the right direction. But you got some of these patients have been on benzos for 20 years. Maybe they can't get off of them. It may be that they will not physically be able to get off of them. They got a permanent state of dependency, just like a diabetic or someone who's been on chronic prednisone, right? You get someone on chronic prednisone, sometimes they're married to prednisone for life. They're not going to reestablish a natural corticosteroid cycle in their body. Some of these patients won't reestablish a natural endorphin system in their brains or the GABA system with the benzos. So it's a complicated medical problem, but the pharmacies need to be a little more educated on just, you can't just cut some of these people off cold turkey. It's not.
But don't you, one of my things is I have an engineering degree across, I've always felt like we should just set numbers. And that if you're not palliative, you're not doing pain like you guys, you should have 95% of your patients less than 50. And the amount of combos you have should be a certain number. And then we give them time to get there and we check them every 6 months and then we get them there.
That may be where we need to go with it to get.
Well, you know better than me,
Yeah,
man. You've done it
yeah,
a long time.
Yeah.
And I don't get to meet with y'all. You know, I'm not allowed to talk to you except in this format.
Which I think is so unhelpful. You know, there's particularly this committee, this is we get $50 and maybe a Diet Coke when we meet. There's no, this is a community service thing, and I applaud the guys that have served on this pain committee because it really is a true, but it's
Well, I'll thank you for the work that you've been doing.
well,
Yeah. Yeah.
19 to 22.
Yeah.
Right? So if you look at non-paying, non-off players, non-college players, all that, they're pretty much all in the orbit of 50. I will say the combo numbers,
Yeah.
like the next game to play a bit. But that's good. Yeah, I can see the improvement on the list. And
Yeah.
certainly, I think the trajectories nationwide, if it's, we just started higher.
We did. We did. And you can't turn that off overnight because that's not,
I know
That's
that.
not
And John
medicine.
knows that. I just,
Yeah.
I feel
Yeah.
bad. It looks like they're shifting the enforcement in.
So-
And just like you said, the mom and pop in Mount Ida gets shut down. Or the mom and pop in
another
Fort
question or
Santana gets
two.
shut down.
The 640 total patients prescribed per month. Have you all maybe internally used that kind of tweaked your algorithm to see whether or not that would change what it looks like with some of our prescribers?
No,
Okay.
since it wasn't one of the finalized metrics, we haven't
Gotcha.
been looking at that.
Do you have the ability to do that?
Probably.
Okay.
I'll check with my epi.
No.
One thing
You got biostatisticians. I mean, I would reverse engineer the formula at this point. If I were them, I would look at, okay, who are my problems?
Mhm.
And then I would turn to my biostatistician and say, generate me a mathematical formula that catches 90% of the problems. And they'll generate this fancy thing, looks like something I might have learned at Vanderbilt, and it will work until the game changes. And that's why I asked y'all, because the game changes, y'all live it.
And I just had two quick comments. You mentioned just making a regulation or a law or whatever you want to call it that says this is the number. Well, I know. And nobody wants to tell a doctor what to do. I mean, that would be crazy. But I will tell you this, it would make our job 100 times easier because then we can just say you're either there or you're not. Right now, there's so much gray area and there's so many, and this comes to kind of part B. There's so much gray area, and just do something when you go back to your district. Just ask your other doctor friends, you ever heard of regulation 2? Just see what they say. Number one, have you ever heard of it? Number two, do you know what's in it? I mean, probably the majority of them will not even be able to tell you vaguely what it is about. And I guarantee you, not many of them will be able to tell you what's in it. And so we had talked many times about having one of our 20 required CMEs, a presentation, 1 hour, either from the committee or just, record it, change it every couple of years, that goes over that. So everyone in Arkansas can't come to us and say, oh, well, I didn't know this.
I feel the same way about that and the foundation.
That was started and then Epic stopped it.
Yeah.
That was,
Oh,
that
we
was
know.
organized and on its way, and then Epic stopped it.
And then one other quick point in relation to the pharmacy, just to kind of let some of the guys on the board know, I talked to a lot of the local pharmacists. Number one, we didn't see these problems till the opioid settlement went through. Number two, so whatever's tied to that.
That's
But
right.
if you're a pharmacist and you try to call the DEA or anyone and ask them, what are the metrics? How am I an outlier? They won't tell you. And then number two, one thing that some of the pharmacists have brought up to me, and this goes back to what Dr. Roman was saying, is the chain pharmacies they don't want to mess with it, or they give you hassle. And so patients go to the mom and pop pharmacies. Well, then that kicks their numbers up, but the patients can't take all their medication to the mom and pop pharmacy because Walmart can fill it for $4 for 90 days. And so then that even throws the mom and pop pharmacy's numbers off even more. So you've got a patient that takes 10 medications, but they take 8 of them to Walmart because it costs them $4. And then they take the others to you. So now your pharmacy is only handing out opioid, which is not really true. You're treating the patient, but you can't compete with the chain pharmacies on the price. And try telling a patient, you either have to fill all your prescriptions here or none. Well, then you've just tripled their pharmacy bill. And they just can't do that. And so then we're all stuck in this kind of quandary where, like you said, I mean, the pharmacies are getting squeezed, the patients are getting squeezed. we're getting calls 10 times a day, changing prescriptions 20 different times, trying to find a pharmacy. Well, then that looks bad on the patient because now basically you're not doctor shopping, you're pharmacy shopping.
Yeah, this is a situation where a company
Yeah.
based in Arkansas could really step up to the plate from a good for the state standpoint. And I don't personally think that's what's happened.
But I had never thought about that till I talked to the local pharmacies on the patients can't bring all their medications there. So that in turn throws their ratios up.
Well,
But if you ask the DEA, are you looking at my ratios? They won't tell you.
Well, and Dr. Tilley, what most prescribers have never heard is part of the injunctive relief, there is a threshold for that pharmacy, and the wholesaler cannot tell the pharmacy what their threshold is. Not that they won't, it's in the
Right.
injunctive relief that they cannot. So you cannot tell me as a wholesaler, well, can I buy 1,000 or can I buy 800? And we're incentivized, if you buy in volume, you get a better deal. It's like going to, your big box wholesaler. But if I try to buy a 500 count bottle and only had 400 left in my threshold, I hit a trigger. It's a suspicious report. It's also reported to DEA. A lot of folks, we get a law course in pharmacy school and have to pass a test. The language of corresponding responsibility, if you've never read it for a pharmacist, it puts the pharmacist at equal risk to the prescriber. And I understand you can say it's the practice of medicine, but it's not. It's the practice of pharmacy. That part of the practice of pharmacy is we have a corresponding responsibility every single time we fill a prescription. And some corporations are saying, just don't even mess with this model or this prescriber. So we really encourage that our prescribers and our pharmacies have a good transition of care plan. If I see an unknown patient to me show up one day and they have an external fixation, I may not have the room to start treating them with the thresholds and limits I have. But if I've had a call ahead and said, hey, we've got a patient that we're looking to transition from hospital to community care, and this is going to be their needs, can you handle this? Then we know up front that I've already built that into where my medications are going. It's tough.
I've got a question. We've had, maybe we addressed it a little bit earlier, but even in the last 6 months, we've had one physician write the board asking us for help, saying that, some of these bigger pharmacies like a Walmart have just shut me off. They haven't been in any trouble at all with the board. I mean, is there anything the pharmacy board can do about that? I mean, it seems like they're just almost playing the medical board by themselves.
So the thing is, with some of our conscience laws and everything else, there's nothing we can do to force them to do it, but we can help to try to get you guys in touch with the people, with those companies that may have decision-making authority. Can't say they're going to change their decision, but one thing about Walmart, and I mean, I think that I think it's at least somewhat public knowledge. Most of these companies, they hire former DEA folks and people with a high level of understanding on how controlled substance, closed system of distribution and enforcement goes. And they are building metrics similar to what you guys are asking Jamie, Dr. Turpin, to put forth with PDMP. And it might be an interesting conversation to say, what are your metrics you're looking at? Like, we need to know, because many times what I have seen or my personal observation is we'll hear there's an issue with a major corporation, and a few months later, there's an issue before the medical board, or there's an issue that we're aware there's a DEA investigation going. So, and those investigations take years. It's just like, if you look at most people that have overdosed, they were introduced to prescription drugs, and there's about a 3-year lag before overdose. So it may not be directly connected to a prescriber, but that may be how they were first introduced to opioids, is what, Brandeis School and everybody else kind of tells us.
Mr. Curley, that's another thing. I've had patients and physicians in my area ask me, that particular pharmacy said they're not going to fill this anymore. Well, that the employees there also you have to buy it from this pharmacy or we're not paying, and then their copay is too expensive. So that effectively cuts the patient off from not just the small ones, but anywhere. Who do we talk to try to get that?
Well, I think when you have issues like that, we deal with a little bit of that, Dr. Phillips, where a patient, and it's not always controlled substance, a patient with their insurance is forced to use a specific pharmacy group that either cannot supply or will not supply a medication. And in general, what I think Dr. Vincent and I would say is, that's really a gripe with your insurance commissioner of, do you have a sufficient network of pharmacies? Because any insurance provider is supposed to have a sufficient network of of what the medical needs are for the patients, they can have it, as well as what the pharmacy needs are for the patient. So if they do not have pharmacies that they can actually get those prescriptions, there's potentially an argument that it's an insufficient network. And so they should open up other avenues for the network.
So getting back to your metrics, a score of 9, that's the highest you can score,
Correct.
correct? Do you find that that score is problematic?
It's not up to me to determine how a physician practices. I don't know the ins and outs of their practice, and the
Okay.
specialty that I send to y'all is what they sign up with their account. That could be true. It's
Gotcha.
self-identified. I don't verify that.
Gotcha. What about
I can
It's
tell you.
usually problematic.
It's usually
Yeah.
a problem.
But
And
like I
that's,
said, it's up for them to determine what's problematic. I just give them the data.
and so is there any way using these metrics that someone could score a 9, but it's, somehow the algorithm just got it wrong with that particular provider?
I mean, I think if it was palliative care, but we try to take them out anyhow.
Oh,
If it's a
I
cancer
agree,
patient,
absolutely.
then we try not to get them. We don't want them
Absolutely.
coming to our committee. They're, that's a very legit practice of
I
medicine.
agree.
But I don't know that we've seen anyone score a 9 that wasn't palliative care, that there wasn't a problem. And those are the ones we went after the 8s and 9s, and we got those corrected off the top. And when you dig into those kind of practices, you saw, some of them were cash only. They didn't take insurance.
Correct.
There was this trend over there on the western part of the state and the Oklahoma border, and they had some of their patients coming across the border from Oklahoma, and we wondered how many were being filled in Oklahoma. Was our data getting the Oklahoma data? There was a lot of that part of the state was pretty hot and still has some issues. Yeah, there were several.
After we changed the metrics, those areas that DEA told us were their hotspots also lit up on our list of places to pay attention to.
Yeah, now in West Arkansas, if you look at prescription per person, which doesn't have any pills in there. Fayetteville, or Washington County, Benton County, and even one of the counties by Fort Smith is actually in a lighter shade on her data. The worst numbers wise on their data in the prescriptions per person bill is Fulton, Hoover, Sharp, Poinsett, Montgomery. And it's a little different spot. So they've made a dent. It's just a question of, that's why I would reverse engineer the number. We're all licensed.
And the Fort Smith problem was a lot to do with across the border doctors filling it. And that makes it almost impossible to accurately assess.
It definitely was challenging, but we saw it light up over there, and
Even though the DEA is not sharing their metrics, have y'all seen any trends in their metrics that you say, hey, we want to add this into kind of where we're going?
I don't know what the DEA does or how they get their information.
Well, it depends. They shared some of their metrics with us, and these are just the agents, not really the data analysis, but really on what they were looking for. And we tried to incorporate that. The main things they shared with us were the pure formulations, high dose. And then they said the biggest thing they're looking at now are the combinations. The opioid benzo soma used to be the big one. Now it's opioid benzo and stimulant. And then you see on the news that now they're pushing the companies to make more stimulants. So, but they're right. Yeah. So those were the big things. And I know we got shut down before, but I still think it's worthwhile to try to push to figure out how we can get that information out there to these prescribing doctors, just to let them know that this, you would be, well, maybe you wouldn't, amazed on some of these doctors we bring up that have no idea what we're talking about. And, I don't know if that's good or bad.
Yeah, we see it too.
You feel bad because they're doing what they think is correct in their mind. And when we talk to them, we can see that, it's easy to see the ones that are obviously doing something wrong and out of touch, but then you see these others that are being pulled up where they really think they're doing the right thing. And then it's difficult to deal with.
It's combo.
Yeah.
Combo. Everybody's looking at combo therapy because the associated risk with increases in overdoses and abuse potential, whether it is controlled or non-controlled muscle relaxants, and then especially stimulants with opioids, it's everybody's trying. The wholesalers are looking at that as one of their major red flags of any type of combination therapy, even down to baclofen.
I'm going to say one other thing, and I think you can speak to this too. Polypharmacy. I mean, I had a patient yesterday. It was a referral, but she's on Topamax, gabapentin, Lyrica. And I'm like, okay, well, we got a lot of redundancy here. She's in her 70s, showed up to the ER confused and delirium, and she's taking opiates. She's taking benzos. So she's got all these mind altering drugs. And so the polypharmacy issue, I think, goes beyond just even muscle relaxers. I think a lot of the neuroleptic meds like the gabapentin and Lyrica are highly overprescribed as well. And they cause a lot of memory loss and confusion. The other aspect, when you're on the front line of this problem, when you address a patient, most of my clinic, I get pain patients from other clinics. They get dismissed. They come to me and they're already on, they're taking 5 Percocets a day. They're on these huge amounts of meds. As you start to work to reduce the opiates, it is such a challenging encounter sometimes. I mean, literally, I have patients, if I don't get Dilaudid, I will kill myself. It's your fault, doctor. We had a patient yesterday. I guess they're going to call the medical board. We're trying to bring their opiate use down, and they're supposed to last 30 days with their meds. They ran out about a week early. They call the office. You got to fill it now. Like, no, you're going to have to dry out for that week. We're going to call the medical board. And then, you get these 1-star reviews because you're a wicked, evil doctor. You're not compassionate. But the clinical skill set to address these patients, to get them involved and to participate in a true opiate reduction program is also it's a skill in itself. And a lot of the pain doctors are interventional based. They come out of their fellowship and they have no idea about opiates. Really, they're just prescribing them. They don't have the skill set, the clinical skill set. You have to get these patients to buy into your program. That is to their benefit. It will increase their pain control, their livelihood by reducing these medications. And that level of skill is not taught. I mean, it's an acquired skill out in clinic because they don't teach you that. And it's such a complicated thing. When you've got polypharmacy, a lot of times I'll move an opiate. I may keep the opiate, then I'll start moving the benzo. But you can't take a patient with multiple drug dependency and just drop all of it at once. You'll have a clinical failure. They're not coming back to your clinic, and you can't keep working with the patient. So it's, the education on 2-4, but there's a huge lack of education in the skill set as a clinician to engage these patients, get them to buy into a proper program to reduce their meds. And that is a huge, I know you've got it. I'm going to kill myself, and I've told we may not be the right clinic, but, then they call the board and say you're,
Or how many times have we threatened to be sued? I'm suing you. I've got probably 100 cases pending.
Yeah. And one funny thing is patient who reported me to the board, I wrote the thing, literally 6 weeks after I responded to the board about her complaint, she calls my clinic. She wants to come back to my clinic. And I'm like, I'm not bringing back to my clinic, but it was just, that's how crazy it is out there. Literally 6 weeks after I responded to a board complaint, she wants back into my clinic. It is one of the more challenging clinical things. It can be mentally exhausting, emotionally exhausting. And then I've got a lot of patients who abuse. I have a Suboxone program in my clinic. I was one of the first Suboxone prescribers in the state of Arkansas. I think too, if you're a proper pain, that's my name of my company, but you should be able to handle drug abuse. If you're going to prescribe opiates and you don't have the skill set to help patients with drug abuse, I don't think you're qualified to be in pain management to prescribe opiates. It would be like a surgeon operating on someone without the skill set to handle an infection. If you're going to prescribe opiates, you're going to see some abuse. You need that skill set to have an outlet for those patients to be able to identify the ones that are drug abusive. And that doesn't mean you dismiss them. I've got a patient who he just got out of the correctional system. He was there for 20 years. I have him on Suboxone. He keeps testing positive I see him every month. He's trying to bring his methamphetamine use down. If I just cut him off because he's got an illicit drug screen and now he's got to go out and seek an opiate, he's going to be back he's going to do a crime. He'll be back in jail. So someone could come to my clinic and say, Dr. Mon, this is not right. He's got an illicit drug. You shouldn't be seeing him. I see him every month. He's staying out of trouble. He's reduced his methamphetamine use. He's no longer smoking it. But I have a great relationship with him and I hope I'm helping. But that's a drug abuse patient. And I feel like I've got to have the skill set to help him. So there's a huge gap in pain management with the ability to handle the complications of prescribing an opiate. And that's something else from an education standpoint that is incredibly lacking.
So what you can start with is what Dr. Tilley said. Let's get the education out about regulation two. It had started, I said epic, I meant COVID, brought that down. And I think probably Dr. Tilley wants to chair that committee is what I would suspect.
He'd be great.
Chairman.
No, well, the
But that's an excellent
education
idea
thing.
because it was started and then got stopped and it needs to be revamped again.
No, I think it's a good idea because like Dr. Roman said, I think you're dealing with two patient populations. You've got the patients that have been on these for 10 or 20 years. And to be honest, they may never come off of these medications. It may cause them more harm to come off the medication than to keep them on it. But then you've got the other subset of the population that have never been on medication. And we've got to try to figure out how to keep them from being put on it in the first place. Because 9 times out of 10, by the time, I don't remember the last time I've ever been the first prescriber of a medication for a patient, ever. Probably in the last 10 years. You know, they come to us and they've been on it, either because they had a bad knee surgery and they've just been kept on medicine for 8 months and nobody noticed. And now we've got to send them to pain management. Or, you know, I hurt my back when I was 21, but nobody did any x-rays. They just put me on medicine and here now I'm 40 and I've been on it for 20 years. And I'm just, I don't know how we do it. I know there's a lot of different, you know, forces that don't want us to require doctors to take certain CMEs, or nobody wants to be told what to do. And, you know, can we make money off of it and all that crap? But I mean, I think it just needs to be just it's easy. Everybody does Zoom. You've got to do 20 CMEs every 2 years, I think it is. Why not?
Yeah. So if we happen to have any providers that we send to the committee, I would definitely appreciate you all's feedback with the appropriate CMEs that they should do, as you're saying.
Well, he's talking about making one on the board site, Brian, and making every licensee in the state and us provide that. I mean, I'm an idiot. I'll get on a video for 20 minutes to talk about something.
Yeah. And we already have a requirement like that.
That's what he's talking about. So
Yeah,
you would
just
maybe get
something
on the
that's
board
simple,
site,
something that
or
could
we
be
hire somebody to do it.
pre-recorded. It
Mhm.
goes over the regulations, talks about what, I mean, if I was a prescriber and out in small town Arkansas, I would like to know what's going to put me up on the DEA's red flag list, because I would like to avoid that. And I think those kind of things are very easy.
Yeah, it'll be good to do, but we're still going to fall into the same trap. You'll have the information there and you'll still have providers that say,
Oh,
oh,
yeah.
I didn't know.
But then they can't tell us we didn't know.
They will.
You're right.
They
That's
will.
true.
But
Thank
take-
you all
but take
enormously
that-
for what you do.
Yeah.
A lot. Thank you
I
so
was,
much.
I was gonna say on a personal note, I appreciate these two doctors.
Mhm.
They see some of my family members. If I have tough patients, I call you up and ask you to help. Here's a different kind of question. So I'm in Fulton County. I'm in north central Arkansas. I'm one of those bad counties, but, you know, we border Missouri, and, Missouri, to my knowledge, is still not on the PMP. They are now?
They,
Okay.
sort of.
Sort of.
There's a St. Louis County PDMP right now that
Wow.
started in one jurisdiction. They've got, I think it's over 85% of that state reporting to them
Okay.
that we do share data with, but they're supposed to get a statewide one this year.
Okay.
It's supposed to stand up this spring, but I hadn't heard.
That's why I was
anything
asking,
about it.
because I've had some patients, not show up on PMP and stuff, and they're going across the border to see a couple of specific pain doctors because of that. They know that now. So, so if they're on the PMP, that'd be really helpful. Dr. Tilly knows. He knows what I'm talking about. So.
Yeah. Yeah. And I don't know all the politics behind the system in Missouri. I mean, I hear the same thing everyone else did, that they resisted a PMP because they didn't want basically doctors being witch hunted with the data.
Mhm.
Yeah. I mean, I don't know all the others. I'm sure there's a lot more, but
Well, has anybody got any more questions? No? If they're still willing to speak to us. Yeah, that'd be awesome. I mean, it's just, you know, I mean, however, whatever the board thinks. I mean, yeah. I feel a
Sincere
lot,
thanks to
I
the
feel like
board.
I understand things a lot better now. I hope everybody else does too.
Yeah.
And it was a plug, a slid plug for the drug summit. I noticed he slipped that in there really quick. I think,
What's
you know,
the date of the drug summit?
November 8th, I believe. And it sounds like I need to add a couple of slides on medical board rule 2. It's rule.
No, I wouldn't want to see them back anytime soon. They're busy. They're already
Yeah.
sacrificing their time. I don't want to make it onerous on them, so.
But I'm just glad we can because I wasn't sure that we could. So we appreciate it. Y'all run for your life.
And might we be able to get some of your slides from the drug summit after?
I'll be happy to send them to you. We're also scheduled, I think John and I are going to try to speak at AMDPA as well.
Wonderful. Thank you. Thank you.